Hi, I'm Riley Agus. I am a student at UAMS. I'm graduating in 2024 with my doctorate of physical therapy. I'm also a current student at Fusion Therapy Center, finishing up my last clinical rotation. So I've got a little presentation for you on cortical vision impairment, as I think it's something that's really important and sometimes overlooked in kiddos that we see in outpatient physical therapy. So here's just what I'm going to plan on covering today. So just reviewing general vision development of infants, how that should look, and then looking at cortical visual impairment, CVI, and then some of the pathologies and conditions that tend to go along with that. And then I want to look at kind of the symptoms, the presentation of CVI, talking about when to refer and what that's going to look like for the patient and the family, and then looking at some intervention strategies and talking about a tool that I've kind of created to work with kiddos in this population in the clinic. So let's look at typical vision development in babies. So this is kind of looking first in utero. So during the fourth week of gestation is when the eyes are actually physically developing. You've got neurons developing, but a little bit later, myelination of all of those neurons connecting them to the brain so that there can be visual pathways around 13 weeks. And then they're going to start developing the ability to see colors around 16 weeks of gestation. But those things are not fully developed once they're born. So as a newborn, they are really sensitive to light. They're not going to see colors as well. That's something that develops over time. You can kind of see in this graphic in the corner, just a general idea of how color kind of develops color vision. So a newborn is going to be seeing a lot more clearly in the peripheral vision versus central vision, and they're not really going to have a lot of fixation on a target. As they get to 2 to 4 months, they're going to be improving the coordination between the two eyes. So before 2 to 4 months, it's kind of typical to see the eyes looking in different directions to business, kind of having them turning in or turning out. That's pretty typical as long as it's not lasting for long periods of time. But around 2 to 4 months is when you should see those eyes start to move conjugately a little more frequently. And that's when they're going to start reaching for objects because they're going to have a little more coordination of hand-eye coordination. 5 to 8 months, that's when they're improving their depth perception. Their reaching is should be increasing with purpose, and it's also the beginning of visual memory, so recognizing objects and people as well. Around 9 to 12 months, that's when we know gross motor skills are really taking off with walking and cruising, standing, things like that. And then they're also going to be improving fine motor grasp with their vision being a little more detailed. They're able to see how far away something is or how big something is, and that's going to really go hand in hand with their grasping. So, vision, why is it important? It drives almost everything we do. It's going to drive the baby's and the child's movement, their head and their trunk control, their balance. They're going to be looking at their environment to be able to tell where their body is in space. It's also, of course, going to be motivating for reaching and communication as well. So recognizing facial expressions and nonverbal communication. Those are all really significant factors that vision helps us with. And then a couple of definitions. So visual regard, which is just having attention to an object visually. Visual perception is that actual ability to take in the sensory information of vision, to utilize that with what the brain already knows has in file and recognize and kind of put the two things together, the sensory information and then memory. So using that to discriminate and understand the environment and things that are in it. And then visual motor control, which we as PTs are very, very involved in. So hand-eye coordination, things like ball skills and jumping and using visual cues to guide our motor development, especially gross motor. But of course, in occupational therapy and speech therapy and some of those fine motor things, we use vision constantly to motivate our kids to kind of guide them where we want them to go with their skills. Just a quick note, of course, I am not an expert, but you might remember some of these things from PT school if you're a PT. I'm still in PT school, so I remember them fondly. But looking at vision and how it is processed in the brain. So we have what's called the anterior component of vision and then the posterior component of vision. So anterior component is what's actually going to create the image. So it's the eyeballs and the nerves that are attaching to the eyeballs. And that's what is actually, the rods and the cones are getting that sensory information information, and it creates this image. And of course, it's flipped upside down and backwards, but that sends it back to the posterior component of the visual system, which is things like the occipital lobe of the brain and all of the other communicating lobes that are going to tell us about the thing that we're seeing. Kind of connecting it to our memories and our experiences so that we can then form a plan of what to do, how to react in our environment. So that image from the anterior system gets sent back to the occipital lobe, which then kind of radiates out into our other lobes. So where our executive functioning is in the frontal lobe, where our memory is in the temporal lobe, things like that. So you might remember there are two kind of what are called streams of visual information for the processing. So we have the dorsal stream, which is often called the where stream. Is kind of looking at spatial processing. So where is the object? How fast is it moving? What is it in relation to? So that stream of vision and visual processing really relies on movement and light and kind of how things are interacting with each other in the environment. And then the temporal track is that what goes through there is the ventral stream. So that's what the what stream. So that's more looking at the actual characteristics of an object. So texture and color, shape and size, things like that, that are more concrete things about that. So that's just a kind of a very, very general overview of the visual processing that goes on in those lobes of the brain. And that's going to be important when we talk about CVI. So looking at CVI, what is it? Cortical visual impairment is a vision deficit due to brain damage or conditions that affect the posterior visual system. So like we talked about before, not the anterior system. There's nothing wrong with the eyes. This is a problem in the brain. And that's what I have here is it's important to remember that this is a brain impairment, not an eye impairment. It's actually the leading cause of blindness and low vision in children in developed countries. So that is likely due to there's increased treatments happening for other visual impairments that are actual issues with the eyes. Those things are being treated a lot more quickly, a lot more effectively now. And so we're seeing a little bit more of the CVI because it's less of a fixable problem. And then as well as there's improving survival rates of children with CNS disorders. And as I'll talk about later, there is a higher incidence of CVI in children who have CNS disorders. So we're seeing higher survival in those populations, which means we're going to see higher rates of CVI diagnoses. About 30 to 40% of children who already have visual impairment, whether that is nystagmus or poor acuity, anything like that, about 30 to 40% of them actually also are likely to have CVI. So it's actually pretty prevalent, and it's not something that a lot of people understand or know about, which is why I felt it was really important to talk about here, because I actually feel like there are a couple of patients that I have been seeing at Fusion that probably are having some gross motor delays that are in conjunction with a cortical visual impairment. So they're not motivated to move because they're not able to understand what they're seeing. About 10.5% of all children that have developmental disabilities across the board are expected to have CVI. So that's a pretty large percentage, especially when that's the majority of the patients that we're seeing here at Fusion. As well as all of these medical causes that I've listed. So these are things that we are seeing on almost every intake form of the children that we're seeing at Fusion. So you have to keep in mind that this is a potential differential diagnosis that you might be seeing in your kiddos. So all these things, shaken baby syndrome, that happens, congenital brain abnormalities. So different malformations of the skull or the brain, strokes and CP especially. So looking down here, up to 70% of children with CP are likely or suspected to have CVI, which is a really high percentage. So it's something that you need to pay attention to and just have in the back of your mind when you're interacting with these kids. They might have a vision impairment. Even if it looks like their eyes work fine, they might not really be processing the things that they're seeing. And again, 64% of the children who have epilepsy, 72% with developmental delays. Developmental delay is like 90% of our treatment load here. And then 20% with genetic anomalies like Down syndrome, things like that. We see those all the time. They might have CVI. And down here again, this is a crazy statistic, but fewer than 20% of cases are likely to receive a diagnosis. So again, this is something that's kind of improving in recognition, and I think that's important. But up until now, it really hasn't received that much of a light on it. And so there are a lot of kids who are slipping through the cracks, and we'll talk about some things that they might be diagnosed with instead. There are three diagnostic criteria. So one is that they have a vision exam, and that does not explain their functional use of vision. So functional use of vision would be such as like interacting with objects in an inappropriate or insufficient way. Maybe, and we'll talk about the symptoms here in a second. But basically, this is the idea that it's a brain problem, not an eye problem. So even if their vision, their acuity is fine, this their functional use of vision is not explained by their eye exam being fine. Number two, a history of a brain condition. So that is some of those conditions that we talked about earlier. That can include things even like prematurity. Also, being a multiple twins are more likely. So just a history of a condition that might cause or be related to CVI. And then lastly is the presence of certain characteristics, visual and behavioral characteristics. There's a list of 10 of them, and I'll go over them in a minute. And then important to note that also a child must be 6 months old before receiving a CVI diagnosis. So like I talked about earlier, some of these kind of abnormalities in vision and eye position, they might be considered normal or at least not concerning for a little while in infancy, just because babies are learning how to coordinate the way their eyes move. So it might not be that concerning. So and it's also really difficult to test a baby's functional vision just because they can't tell you what they're seeing or how they're understanding the world. So just keep in mind. So looking at presentation, it is very varied between individuals. So some kiddos are going to have really distorted vision. It's going to be a really confusing thing and that's maybe a more severe case where they're not really able to even see anything clearly. There are certain conditions where they have difficulty seeing a whole image at once. So they might see, someone described it like Swiss cheese, like they're seeing through holes in Swiss cheese. They're seeing just little parts of an image. It's really hard to bring that image together into one meaningful thing. Others, like I said, they could have fine visual acuity. They might be able to see fine, but they struggle to understand and have meaning with what they see. So it just might not be a meaningful vision, functional vision again. They are really likely to have impaired visual fixation or following. So that's something you'll see in infancy. When we're working on reaching and rolling, they might not, be motivated to look at an object, and they might seem to have really poor fixation. Visual fatigue is really common with these folks. It's something that even after a long period of treatment, they are still likely to deal with is visual fatigue. Which may show up in younger kids as outbursts and behaviors and things like that that appear maybe like an emotional regulation issue versus fatigue, visual fatigue. It is really common for them to have poor acuity, so they might already have, like I said, a visual diagnosis, they might already have glasses and things like that. It's pretty common. One thing you'll likely see is a decreased regard for faces. Something that parents might bring up is avoidant social gaze. This is why you'll see, yep, down below, it can be misdiagnosed as an emotional or psych disorder like autism spectrum disorder. So that lack of eye contact, it might not be because of autism. It might be because they cannot understand what faces mean. And like I said, this can be really overwhelming for kiddos. It might lead to a presentation of being really anxious in new environments or with new people that they are not familiar with. And it might lead to frustration and avoidance behaviors, even avoidance of looking at objects or at faces. Strabismus, like I talked about earlier, so eyes facing different directions, face coming together, is really common as well. So you might see that. And then, of course, with the eyes being normal, pupillary reactions should be normal unless they have another diagnosis. So here are the 10 characteristics of CVI. It is called the CVI range, and this is how they quantify this information for a diagnosis. So Each of these receives somewhere on the scale of 0.0 to 1.0. And so altogether, it'll be a score of 10 points. So lower points would mean that they have lower visual functional vision, and higher would be higher functional vision. So these are things that you can look out for, or that parents might mention, or signs that would point you to maybe make a referral to a pediatric ophthalmologist, a neuro-ophthalmologist, maybe back to their neurologist if they already have one, or pediatric low vision specialists, just someone who can do the actual CVI testing, the CVI range, to ensure that those kids are getting the treatment that they need as early as possible, because faster treatment options means that they have better outcomes. They're more likely to recover that vision. And we'll talk about that in a second as well. So color preference, it might be easier for them to see or to fixate on colors red and yellow. Need for movement. So that has to do with the dorsal vision pathway. So if maybe their ventral vision pathway is a little more impaired due to that CNS disorder, they might be able to process things better that are moving, because that dorsal pathway again processes things that are moving or light and things like that, versus concrete things about vision like space and or like size and texture and things like that. So and they might be able to see or pay attention more to things that are moving. Visual latency or delay, so not following an object right on track. A lack of visually guided reach. So of course, we're working with kiddos all the time on reaching and rolling in supine, especially the littles. And so maybe if you're not seeing that for a long time, and you've worked on it and you've worked on it, and it just doesn't seem like they are interested in reaching for an object, it might be because they can't comprehend that it's something that they could actually touch. Visual field preferences, so that can play a role in torticollis, things like that, which can obviously has great implications across all of PT, OT, and speech. So important to just be aware of that. Difficulties with visually complex scenes, so kind of if they're looking at a book with lots of pages, they might have really hard time understanding what's going on versus something that's on a plain background. Light gazing, so that's another thing. It might be another reason that kiddos are misdiagnosed with autism. It might look like stimming, looking at lights because they are able to see it. Again, that dorsal pathway is able to see and comprehend light better. Or non-purposeful gaze, so just looking elsewhere, like anywhere other than what you're showing them. Difficulty with distance viewing, atypical visual reflexes. So visual reflexes being like the protective corneal reflexes, like if they don't have depth perception, they might not be able to see that something is coming towards their eye. They might not react with a blink. And difficulty with visual novelty. So this goes back to kind of, they are able to understand things that are familiar to them a little bit more than they would be with a new thing. So, and we'll talk about that in a second as well. So intervention strategies, this is kind of intervention, kind of also just how you would look at patients in at different levels of CVI. So they have categories. So based on that CVI range score that we talked about a second ago, they are in one of three what are called phases, which are basically placements on the continuum of visual development. So if they score low, again, that is meaning that they have the most severe impact on their visual function. And when you're doing interventions with these kiddos, the goal is to build consistent visual behavior. So really, and this is, again, this is the intervention specifically for vision therapy. This is what a vision therapist would be doing with them. But these are great things that we can incorporate into our daily treatments, because obviously that vision is going to change everything about their development. So we need to be aware of the ways that we can interact with them in a way that's more effective for them, even if it's not directly doing vision therapy. So in this phase one, that most severe impact, they're rarely going to have direct eye to object visual skills. They're going to have a really hard time visually fixating. So what we're going to do is provide opportunities to use the available vision. So what we're going to do is give them things that are very low complexity, and that includes sound and textures and things like that, just very low complexity. So keeping things the same color, the same texture, a preferred color, a bright color against a dark background, Also objects with movement. So really relying on that dorsal pathway because it might be stronger to help them to develop a connection of between the eyes and the brain. So things that have shiny or reflective surfaces are going to give the illusion of movement, is what it's called. So using toys like that might be easier for them to see things like a mirror or it's like shiny plastic things. Um, and again, limiting complexity. Oh, here's an important thing, especially for PTs, OTs. Sitting, standing up, any kind of physical activity is going to be even more stimulation to their entire body. So remember that it might be even harder for them to focus or to understand their vision when they're also being asked to keep their tummy turned on or keep their head up, things like that. So it might be more difficult for them to understand visual stimulation when they're already doing a gross motor activity. Phase two, a little bit higher score, just a moderate impact on their visual functioning. And their goal here, oh, and again, I guess not again, but people who are in one level of CVI can progress to another level. So that's why they have kind of goals for each level, is that they can build upon one. So they might start as a phase one, but then they can move to a phase three by the end of their treatment or anything. So our goal here in phase two to integrate vision with function. So getting the child to consistently look at objects and reach and make a connection that if I can see this thing, I can touch this thing and it can do this. So it's encouraging interaction with their environment, with objects and things like that. This is hopefully when they're going to start fixating on an object. They might look at it, but they still will probably have difficulty understanding what they're seeing. So one thing that we can do is what it says here, supporting vision with language and comparative thought. So that's talking out loud to the child about what it is that they might be seeing, talking about colors, talking about textures or sounds or what the item can do or what it means, what it is. So using comparative thought and language to help them to start to understand their environment and objects in it. Again, continued use of a plain dark background can be helpful to guide their reaching, and then allowing additional wait time. So they might just need a little more time to understand what they're looking at. Even though it seems like they're looking at it, if it seems like there's a delay, they might just need an extra second or two, or even longer to kind of understand what it is they're looking at. And you can document that, but it might not be a gross motor issue or a fine motor issue. It might be that they need a second to understand what that toy is before they reach for it. And then lastly, a score of 7 to 10 is going to put them in phase three. That is the closest to typical visual functioning. But people with CVI cannot fully resolve their CVI. It doesn't ever become typical visual functioning. They're likely going to deal with these symptoms forever. So things that are really complex or that are novel might still be really hard for them to comprehend. It might be disorienting, as it says. So, of course, in phase three, our goal is just refinement and working on really using this vision functionally. You can, it's kind of like progressive resistance. We can gradually increase the complexity. So that might look like in a therapy setting, it might look like being in an individual treatment room for the first while with minimal toys, minimal sound and lighting and things like that, and then slowly moving out into the gross motor gym and things like that. And then this is going to be important as they get bigger, as they start going out into the world, they go to school. It's going to be important to focus on learning how to kind of navigate areas that are new and that require increased reliance on vision. So places that have uneven surfaces or a sudden drop off or a step down, and just new settings in general. Or like I said, kids going to school for the first time, navigating a setting with lots of people walking around. It might be difficult, but that's something that we can definitely be a part of helping them improve. Um, Here are just a couple of kind of last thoughts that I had and that I found in my research, intervention strategies and tips. Remember that neuroplasticity exists, that it's amazing, and that is what allows us to improve the child's functional vision. So because this isn't a physical issue with the eyes, they are able to improve those connections, especially children, because children have such higher neuroplasticity than adults. So they're able to increase their functional vision with training and practice and specifically specific interventions for them. And like I said before, if you're seeing these signs, that does warrant a referral to a vision therapist, and they're going to do much more targeted therapy for their eyes, and they are able to improve that over time. Another thing to keep in mind, maximize the child's alertness. Learning, of course, learn the best when they are active and alert and ready to learn. Lights, color, action. That is one of the main organizations for CVI support and research. That's kind of their phrase that they like to use. Lights, color, action is just a way to remember the best way to interact with people who have CVI is that colors and lights and movement are going to be the best things for them to be able to see, and it's going to help them to interact with their environment best. So, like we said before, using color, red and yellow are actually the easiest to see. That's actually true as well in development in general. It's almost like they're going through vision development just at a later time period. And then using lighting to attract attention, of course, like we said, lights are going to be easier for them to see, and reducing visual complexity, of course. When that child is ready, that's when you can start to, increase the complexity, start including sound and touch and the other senses so that they can start connecting things in their environment. And then slowing down, like I said before, waiting for them to have a reaction if they need that time to comprehend what they're seeing, but also breaking tasks down into really small, especially when we're doing things like environment navigation, especially in novel environments, slowing down the activity, doing part practice to help them. And then I've got a little, this picture over here. There are apps for kids with CVI that have different, like high contrast backgrounds and images, things like that. These are things you could suggest to parents, games to play, videos to watch that can kind of help support their developing vision. And that's one important thing to kind of talk to parents about if the child has a diagnosis of CVI after that, that, like we said, neuroplasticity allows the brain to continue to improve. So they need stimulation. It's not better for them to just only use completely plain background, high contrast things forever and ever. We want to slowly increase that stimulation because they are able to improve over time. Okay, so lastly, I'm going to talk about the little room. So this is a concept that was developed in the 1990s for blind and visually impaired children to help them kind of interact with their environment. Was designed to increase reaching and exploration of their environment, and it really helps to improve their spatial awareness and their confidence in movement and in interaction. So basically, it's a structure that is small enough to, the idea is that no matter what direction the child moves, they're going to touch something. They're going to feel something with their hand, and then they might be able to connect that with vision slowly over time. Or if they don't even have vision, it still encourages them to start exploring their environment, because blind people who are blind often actually develop movement patterns that are more inward towards themselves because they're not confident in moving outward because they can't see the environment. So we see that in little babies. Blind children often don't even begin reaching until they're 10 to 12 months old, if they do at all. Whereas we normally would see that 3, 4 months, something like that. So that's the idea of this little room. And I want to show you what I have created. So I've created kind of a modified version of a little room, and that's what I've got over here. Um, so this is something that I have built. I'm going to leave it at Fusion. Hopefully it can be useful. I think that it could be useful with both children who have visual impairments as well as those who don't. So just starting with like the basic structure, this is pine wood. It's supposed to be non-allergen producing, so hopefully safe for all the kiddos. I did use a baby safe paint and sealer, and then it's got a top coat on it that should technically be food safe. So the basic structure, like I said, this is something that you could lie the baby down underneath and they could look up. So what I've got is you can see these lights. So I do have a little remote. They're kind of mounted on there. So I've got lights. And so, like I said, movement and light are things that kiddos with visual impairment are going to be able to see a little better. Lights like this can encourage reaching and rolling. They don't all have to be on. You can turn them off and on. You can have any one of them on if you want to turn it around, have their head closer to this lower side, or turn around, have it closer to the higher side, whatever it is that they need. You can have it flashing, you can have it on both sides. And then on the top, be able to see, I've got lots of little holes. So those are to let light through from the ceiling lights. So if you've got lights on in the room, so that this might promote some gaze upward if they're having, a visual field deficit or tending to look to one direction. This might promote some upward gaze. You can take a cloth or whatever, cover one side and only have them under the other side, or cover them all if you really want to, if you want to just focus on those side lights as well. Also, these poles are kind of useful. We can attach things like rings. We can put beads down through these holes in here. I've got some attachments in several different slots. So they can go here. We can work on reaching. So this of course can be used for a typically developing infant as well. It can also, it's sturdy enough. They can use it. We can use it for pulling up practice, things like that. And then I want to show you inside. So inside, again, you can see these little holes that are great for just contrast and visual stimulation, looking upward. And this is what baby's going to be looking at on the top. Once they're inside, they're looking up. They can see this, which moves. So movement, again, is going to help them develop that vision. Multiple colors, it's very high contrast. You can also use this, have baby on their tummy, looking up, doing some cervical extension, looking at this, maybe reaching for these, reaching for beads. You can hook whatever you can figure out to hook in any of those holes you can. Of course, you can cover this up, take these away, and only have the lights on one side. Only have the light on that is higher up or that's lower down, anything like that. You can really put these kind of anywhere. So that is my version of the little room. I think it would be good for anyone that you might suspect does have a CVI, but also those who don't. Even little babies, they are going to benefit from being able to see little, typically developing babies are going to benefit from being able to see things that are high contrast, high colors. This is all going to support their vision. So you can really use this with any patient population that you might think benefit from it. So I hope that it's useful to you guys. And I just want to thank you for paying attention to my presentation. I appreciate y'all watching. And then here are some of my references. All right. Thank you. Bye-bye.